Okay, everybody, welcome back. So we've talked about the phases of an EMS call as an overview, and we've gone over scene survey and talked about provider bias. And now we're going to talk in more depth and detail about the primary assessment. You've heard me mention a lot of these concepts already. What I'd like to do now is go over them with you in a bit more detail and really be more thorough about what we're talking about in that primary assessment in that transport decision. So your primary assessment is gauged or is developed to help you determine an index of suspicion. And what I mean by that is how suspicious are you that this patient is indeed critical and in need of immediate medical intervention? Okay. The primary assessment isn't designed or intended to be diagnostic. Rather, it's for you to identify with some level of certainty how critical this patient's going to be and what interventions, what life-saving interventions may need to be performed immediately, and how fast we need to move this patient into or out of definitive care. Okay, so we're gonna start to develop that index of suspicion. Things that are going to be important, right? Is the patient's position and their environment. We talked about this a little bit with the last lecture. The level of consciousness again, and ABCs. Your transport decision. You're going to see the CUPS acronym again. We've talked about that several times, so hopefully that's starting to stick a little bit with you, right? Stable, potentially unstable, unstable, or critical. Okay, and we're gonna develop all of this information so that you have a clear pathway, right, to be able to make an educated guess about how critical these patients are and what your next move should be, whether they're stay and play or load and go. Okay, reminder: this primary assessment really should take less than 2 minutes. Okay. 60 seconds is kind of the target. Shouldn't take you very long at all because we're not being diagnostic. We're just trying to identify at what level of risk the patient is for an immediate need for intervention. Okay. So, one, patient positioning. Okay. This is info that's derived from your scene survey. Okay. If you remember, we mentioned about noticing what's around the patient. Okay. Is their environment centric to that single location? Okay. And whether or not they're natural or unnatural. So if we look at this image here, we can see a couple of things. The patient looks to be alert, right? So patient looks to be engaged. She appears to have her eyes open. She's holding herself upright. She has a posture about her. So she doesn't appear to be in an unnatural position. But what else do you notice about the environment here? We've got some books, we've got some medications, we've got mail. Okay. Looks like baby formula. So perhaps this is new mother. Okay. You've got pillows and blankets and maybe a handbag or some packages here, a book bag. Okay. This environment is very centric to this patient. And what I mean by that is this patient is probably not very mobile currently. Okay. Gauging from the situation, this is probably a new mother who's probably trying to nurse with the Vaseline here, okay, is supplementing with formula, okay. So that tells you some about the environment that the patient's living in, maybe the conditions, maybe things that are going on in her life that are important and may be relevant in need for her. Okay, so she's in a natural position. The space is relatively centric, but it's relatively clean. It doesn't feel like she's been there for an extended period of time. There's no immediate need to move her into another location, right? And what I mean by that is she's not in an unsafe environment. It doesn't look like anything's going to collapse around her or something there that we may need to move her away from. Okay, so we're looking at that patient positioning there. All right. One of the things to keep in mind as we go through this, your primary survey is only required, the only time you stop your progression, right? So level of consciousness, airway, breathing, circulation, disability, and then exposure. The only time that you would stop doing your assessment is to intervene in a life-saving way, right? So if she needed to immediately be extricated, we would stop here, pull her out of the scene, move her to a place that's safe and secure, and then we would continue our primary assessment. So we've got our level of consciousness and we're we've looked at the patient positioning. The next thing we're going to assess is airway. And this is a cross-section of airway. And you've talked a lot about this already in anatomy and physiology, but just a kind of a brief overview for you. Airway patency means that the airway path, okay, nose, pharynx, trachea, is clear. Okay, so there's nothing obstructing that. The primary obstruction to the airway, okay, is the tongue. That's the most common airway obstruction. And we can correct that, and you're going to know that airway is obstructed by the tongue by a couple of things. You'll have what we call sonorous respirations or snoring respirations, right? The sound of the tongue somewhat occluding that airway, okay? You may also hear sounds that sound like gurgling, and that would be liquid in the airway. Or if the patient has a completely occluded airway, meaning completely obstructed, you may hear no sound. Okay, so that can be a foreign body airway obstruction, or it could be a pathological process. But we will stop our primary survey to intervene if there is an obstructed airway. So things that we'll need to do to be able to do that. So if there is a gurgling sound like a liquid, then we'll use a suction device. A rigid suction catheter will be introduced into the mouth, and you can suction the liquid out of the oropharynx, that's this area here, okay, or perhaps the hypopharynx, this area here, all right. You can suction that liquid out. We'll go over that procedure in lab. If it is sonorous respirations or snoring respiration, the best way to open the airway is to do airway positioning, and that's for your patients who've not had a trauma, a head tilt chin lift. So you take one hand and place it on the back of the patient's head. You take your other hand under the chin and you tilt the head back and lift the chin to bring the head back, and that opens the airway, okay, and removes the tongue out of the base of the airway. If it's a traumatic patient where you don't want to manipulate the spine, okay, you'll use a jaw thrust, and we'll show you this procedure in lab. You'll take 2 fingers on the mandible and push the mandible forward. And by pushing the mandible forward here, it pushes the tongue out of the hypopharynx or the oropharynx in this area. Okay. You also have adjuncts that can assist with this. So you have an OPA, that's an oropharyngeal airway. The oropharyngeal airway actually goes into the mouth here and rests at the back of the tongue. Try that with a different color here. A little easier to see. So the oropharynx, that's this device that you see here, rests in the outside of the mouth and is curved, as you can see, and goes back to the tongue and helps hold the tongue forward. Okay, so it pulls the tongue out of the back of the airway. This is the oropharynx. You can see I'm measuring here from the corner of the mouth to the curvature of the mandible. Okay, and that's proper sizing. All right, the nasopharyngeal airway is similar, except for it goes into the nose of the patient. And so the nasopharyngeal airway is measured from the nares, or the nasal opening, here, okay, to the curve of the jaw as well, or we can measure to the earlobe. We'll go over that procedure in lab. And it's inserted into the nares, and again, sits back in the hypopharynx and makes sure that there's a patent pathway for air to travel. Okay, so that's your NPA and your OPA. Your OPA, or your oropharyngeal airway, is used for patients who don't have a gag reflex. Your NPA is used for patients with a gag reflex. Okay? For advanced providers, so if you're training as an EMT or a paramedic, and you're looking at advanced airway techniques, and this is predominantly for paramedics when we talk about things like intubation, okay? Advanced airway procedures are only used when basic maneuvers fail, right? So if we can maintain a patient's airway patency with an OPA, okay, or a head tilt chin lift, then we're going to wait to intubate until later in the care spectrum. Okay, we may decide to intubate during the secondary survey or during treatment phase while we're transporting, but the only need to stop what we're doing for the patient primary survey to intubate is if these procedures are failing. Okay, airway management is progressive. Likewise, if suction works, then we'll use suction, but we may choose to intubate this patient later. Okay, However, if these are failing and you can't maintain airway patency, then we would move to the more advanced intubation procedure. Right. So that's airway. Let's talk about breathing. In the primary survey, we're really only looking to whether or not breathing is adequate or inadequate. Okay. We're looking for chest rise and fall and a respiratory rate. And we're not measuring a respiratory rate. We're really just looking, is it within that normal range? Okay. So roughly 12 to 20 a minute. Is the patient moving adequate air? Do they have adequate chest rise and fall? If they don't have adequate chest rise and fall, okay, we need to determine, one, is it an airway issue? All right. So if your airway isn't patent, okay, they're not going to be able to ventilate appropriately. So if the airway is patent and they're not ventilating, then we may need to assist ventilations. Okay. And the tool that we use for that is the bag valve mask. The bag valve mask, this tool here, comprises of a mouthpiece. This goes over the patient's mouth, and a bag that we squeeze to assist the patient in ventilation. Okay. The first order would be to assist ventilation with just the bag valve mask. And then if we were unable to assist the patient with ventilation with just a bag valve mask, then we may use a ventilation tool such as a BIAD, or blind insertion airway device. This is a King LT that you see here. Understanding that this is, the name is a bit deceptive. The term BIAD, blind insertion airway device, is not actually a device that secures the airway. It is a device that helps deliver directed ventilation. So if we look here at the airway, so if we were ventilating the patient with a bag valve mask, the mask would sit over their face, right? And we would push air down into the lungs. That would be the goal. Things that we'll talk about in lab, and when we talk about airway emergencies, there's some risk by doing this because we may inflate the abdomen. Air really can go in two directions. It can go into the trachea and into the lungs, but it can also go into the esophagus and inflate the abdomen. And for the advanced level providers out there particularly, we know that when we inflate the abdomen, that we can cause an increase in intrathoracic pressure, which reduces cardiac output, and that can be problematic. So we can use a tool if we're having difficulty getting good ventilation for the patient, and that's where the King device or the BIAD comes in. This device is inserted, the balloons are deflated, it's inserted into the oral os, into the mouth, back into the hypopharynx, and then we inflate the balloon. And when you inflate the BIAD, you should not be holding on to it because it's going to self-seat. It's going to raise itself up, and the larger balloon is going to sit in the oropharynx here, the hypopharynx here, and the smaller balloon will likely end up in the esophagus. The balloon in the esophagus inflates to prevent air from going into the esophagus, and the larger balloon inflates to keep air from coming out of the mouth. Inside the King LT particularly, and the LMA is similar, as is the iGel, there is an opening right here where air is then ventilated directly into the glottic opening, right? So the epiglottis sits here, pushes air into the glottic opening. And so this tool, the bag valve mask, you remove the mask and connect it to this piece at the end. Now you're able to deliver directed ventilations into the trachea, so it's getting directly to the lungs. That bypasses the esophagus to prevent gastric insufflation and delivers a bit better ventilation when used appropriately than a bag valve mask by itself. Okay, a lot of information there, I know. We'll cover a lot of this in lab. You'll get to put your hands on these pieces and make a little bit more sense. Okay. A reminder though, again, bag valve mask is the first line. The second line is your BIAD, right? So we use a progressive approach to management. We start with a bag valve mask. If that's not working appropriately, then we move to the next device. Okay? So, and we're only stopping these for life-threatening problems, right? I think we all could agree that an occluded airway where a patient can't move air in and out is a life-threatening problem. A patient who's not breathing is a life-threatening problem. Okay? Likewise, when we get to circulation. Okay? So we move through A, we've moved through B, now into C. We're going to reach down quickly to see if the patient has a radial pulse, right? If they don't have a radial pulse, we're going to check for a carotid pulse, okay? We're really just looking here is the pulse present? Yes or no? Is it fast? Is it really fast? Is it really slow? Okay. Their skin color, you can see that as you approach the patient. Does it look pale? Okay. Skin temperature, right? Are they cold when you reach and feel for a pulse? Are they diaphoretic or wet? Okay. That all gives you an indication about their perfusion status. Is there any uncontrolled hemorrhage, right? So as you're approaching the patient, do they have a spurting wound on their arm or their leg or their abdomen that needs to be occluded, right? And it's worth noting at this point, if you're approaching a patient and you've got into the approach the patient phase and you're walking up to them and you notice they're actively bleeding, you don't need to go and assess airway before you stop the bleeding, right? You found an immediate problem, fix it, and then go back to your airway, your breathing, your circulation, okay? If they're actively hemorrhaging when you get there, stop the hemorrhage before you start doing other things, right? Because we know that's a problem. Once you've gotten this information, right, now we can make our transport decision, right? The old school methodology was the sick versus not sick. We don't really use that anymore because patients aren't really going to all fit into that binary world of yes or no. Okay. I prefer to use cups. I think that's a great way to give them a scale of criticality for how sick the patient is or how not sick they are. So for stable patients that their level of consciousness, their ABCs, the primary survey checks out, stay and play. That's where you're going to do your secondary survey, your vital signs, etc. Get your history. For your potentially unstable patients, these are patients that may have some deviation in that primary survey, right? Perhaps they have a good airway and their breathing and their circulation is good, but they're unconscious, right? Those are going to be load and go. For your unstable patients, these are patients you're going to stabilize and then transport. So for example, if a patient is not ventilating, not breathing, right, you're going to need to start ventilations for that patient to stabilize them and then transport. If your patient is actively hemorrhaging, right, they've got a spurting wound on their leg, you're going to put a tourniquet on it and then you're going to transport. Okay. Critical patients, these are patients that you may need to transport right now. Okay. These are patients that are immediately in need of definitive care. There's nothing you can do for them. Okay. Note about cardiac arrest and transport. So in times past, cardiac arrest was considered a critical rapid transport event. And so we would throw folks in the back of the ambulance and try and do CPR while driving down the road and get them to definitive care. What we have found in the last 10 to 12 years is that the best chance a patient has for cardiac arrest survival is when and where they are rested. Because the things that make a difference for cardiac arrest are CPR and defibrillation. Not a cath lab, not paramedic medications. The best chance a patient has for a survival is early high-quality CPR and early defibrillation. So cardiac arrest now, for best practices, should be performed on scene. There are exclusions to that. So things like a traumatic arrest, where you may need blood products or surgery, or times when the scene has become unsafe during a cardiac arrest, where you may need to transport that patient. But by and large, the vast majority of your patients, you should be working the cardiac arrest on scene. Because the time it takes for you to move the patient to the stretcher, move the stretcher to the ambulance, trying to do CPR while bouncing around the back of the truck, your CPR quality goes way down. And that actually prevents the patients from having a better chance of survival. Okay. Reminder as we go through, primary assessments are not linear, right? As you approach the patient, right, if they're obviously hemorrhaging, it's time to stop the bleeding. Likewise, if you walk up and you see a patient is not breathing, before you assess anything else, you may need to start ventilating that patient. Or if you approach the patient and they don't have a pulse, start CPR while you assess the airway. Okay. It's not linear. You don't have to get through A and then get through B and then get through C. You fix it as you see it when you approach it. Okay? All right, we'll see you on the next one.